Hi guys, welcome back to the next, our final part of the endocrine lectures. We're going to talk about the thyroid for the next two lectures, and this first session is about the nodules. So not the thyroid disease, but thyroid nodules and how to work them up. So the relative short one, the part two, is some of the thyroid disease that you need to know, and we'll cover those, and the rest of it will be covered in your internal medicine lectures. All right, so let's get started. So some of the questions that you want to answer after this lecture is, what size do you get worried about it for the thyroid nodules? How do you medically treat it? What surgical options do you have? What is the use of fine needle aspiration in thyroid cancer? And when do you do total versus partial thyroidectomy? All right. So a couple of things before we get started is let's review the anatomy. So this is your thyroid gland, right? So remember from our previous lectures, the parathyroids are literally right behind it, right? And it's right next to the common carotid arteries. What's more important about the anatomy here, the questions I will ask you, is the recurrent laryngeal nerve and the superior laryngeal nerve. So the recurrent laryngeal nerve, it's the branch of the vagus nerve. So on the left side, it comes off the vagus, but it recurs literally right under the aorta and comes back to where the thyroid is going to be, which in this picture is kind of like right here and right there. And the superior laryngeal just comes up superiorly and enters through there. So what is this recurrent laryngeal nerve innervate? This picture actually shows it better, right? So this is the left one goes right under the aorta, recurs into the thyroid, and the right one goes under the subclavian artery, the right subclavian, and it innervates essentially every single muscle except cricothyroid. And the major thing that you need to remember, the muscle function of the recurrent laryngeal nerve is it controls your vocal cords. So when you're talking or eating, right, your vocal cords close because you don't want food to go down your windpipe, right? It's going to go in your lung. It's called aspiration, right? But when you're breathing, it opens. And that's what the recurrent laryngeal nerve controls. When it's paralyzed, right, here you can see that it comes all the way to the middle. The left one is paralyzed. It doesn't come to the middle to keep it closed. So that shows the left one is paralyzed. And they can show you this on the exam, like which nerve was injured or what kind of surgery did this patient have. And you know that the recurrent laryngeal nerve literally goes behind the thyroid. So, thyroid surgery, parathyroid surgery is a very high risk. And we discussed it in the parathyroid lectures. This is a very common risk. And this is also a big risk, one of the biggest risks, complications of the thyroid surgery. Superior laryngeal nerve. The only thing you need to know for the superior laryngeal nerve innervates the cricothyroid muscle. Every other intrinsic laryngeal muscles are controlled by the recurrent laryngeal nerves. So this one's controlled by the cricothyroid is controlled by superior laryngeal nerves. And the only thing it does, it controls the pitch. So if you want to get higher pitch sounds, right, or for opera singers, if this nerve is injured, then you'll have some symptoms. But otherwise, in a normal person who's not an opera singer, which majority of us are not, then you will not have any symptoms. Couple things. Quick embryology, because it'll be important down our lectures, right? Thyroid starts at the base of the tongue, right? It's called the thyroglossal duct. It uses the thyroglossal duct to migrate through the middle of the hyoid bone down to where it is right now, right? So the duct, kind of like a bile duct, lets bile go through. The thyroglossal duct lets the thyroid kind of migrate to where it is now. So it's always in the midline, right? And it becomes important, and we'll discuss a couple of the diseases later. But remember, it goes down the midline. So what does the thyroglossal duct cyst, right? So thyroglossal duct should close after thyroid goes to where it is, right? But if it remains open, it can become a cyst. If it collects with fluid, it can get infected. But one of the things they'll tell you is that mass moves the protrusion of the tongue, right? Let's look at the picture, right? Because it starts at the base of the tongue, right? And that duct goes all the way here. So if you move the tongue, this whole thing is going to move, and your thyroid, the cyst is going to move with it too. So that's like the buzzword that they use. So before we go on, let's talk about a couple of things about the thyroid gland and the thyroid hormone, right? The thyroid gland releases T3 and T4. So anything that's a primary disease, that's a primary hyperthyroidism, is going to have elevated T3 and T4. Now, T3 is the active form, is a more potent form, and the T4 is less potent, but it can be converted to T3. So you make a lot more T4 than T3, but T3 works a lot better, right? So that's what you use to control it. What gives it a feedback? So if you have T3 and T4, which controls your metabolism, growth and development, and increases your catecholamine effects, if you have right amount of it or too much of it, what will do? It will suppress your thyroid stimulating hormone, which is released from your anterior pituitary. So anterior pituitary releases TSH, thyroid stimulating hormone, to your thyroid gland. Thyroid gland gets stimulated and makes T3 and T4. All right. One thing, thyroglobulin, not a total high yield, but it'll be helpful on awards. Thyroglobulin is like the backbone where the T3, T4 is made. So what it is just it's a good indicator of how much thyroid tissue you have. So when is this important? So for example, you do a thyroidectomy for a cancer patient and you want to know if there's any cancer left behind. That means any thyroid tissue left behind. So you could measure thyroglobulin. And one thing they'll ask you on the awards is like, how do I know if that value is false or true? Because some people can make antibodies against thyroglobulin. So you want to measure the antibodies in thyroglobulin because you want to make sure if the antibodies are suppressing that number. That's important to follow the cancer patient. So if you're in endocrine surgery, you will stumble upon this. All right, so let's start with the high yield things. So if you see that they mention a neck mass that moves with swallowing, they tell you that's a thyroid involvement. That doesn't mean necessarily it's a cancer, right? It will discuss what makes you think it's a cancer versus a benign thyroid disease. But when you breathe, right, your thyroid is really attached to your larynx. Right? So when you breathe and or when you swallow, right, since it's attached, your larynx and your pharynx move a lot. So your thyroid is going to move a lot as well too. And another important thing, we discussed that the thyroglossal duct cyst, it moves down the midline, right? So if you have a thyroid tissue in the lateral compartment of your neck, in your lateral neck, that is not supposed to be there. That should tell you that it's a thyroid cancer metastasis to your lymph nodes. And we'll discuss what's the most common cancer that you have to worry about. So that normal thyroid tissue is usually midline. If there is a lateral thyroid tissue, you should worry about a cancer metastasis of the thyroid gland. Thyroid nodules. That's the most common presentation regarding the thyroid mass in the general population. It's usually asymptomatic mass. You just kind of, in the morning when you shower or you look in the mirror, you see a mass. And they'll tell you that it moves with swallowing. That should already, warn you that's a thyroid issue. It's usually, euthyroid. It doesn't release hormones. That's just a thyroid hormone, but since it can get really big, it can cause compressive symptoms. So what are compressive symptoms? It can get big, it can hinder your larynx, so get difficulty breathing especially when you're laying down, because they'll just press on top of it. You'll have voice changes because your nerves are around it, and you could just push pressure on the nerves. And dysphagia, and literally it's right behind the larynx is your pharynx, right? That's where your esophagus starts. By compressing that, you'll have problems in your esophagus. And this is usually what, this is really big to get to, but it'll show you this on the picture so you don't have any kind of qualms about what they're trying to show you. But usually they're a lot smaller than this. So what can it be? So obviously if you see some kind of mass, you're always worried that it's a cancer. But actually 95% of them are benign. So that means majority of the time it's going to be benign, but you want to still make sure that it's not a cancer. So the general approach before we go through the algorithms is you want to make sure that if it's a functional versus a non-functional one, right? After you determine that, you determine if it's malignant or benign, right? Because you want to find out if it's actually releasing thyroid hormone. Because what's the gold standard of diagnosing a cancer? Is always a biopsy. And would you want to biopsy a nodule that is releasing hormones? No, because you're going to release it all over, and you can cause a lot of complications. So first you want to make sure it's functional versus non-functional. Then you find out if it's malignant or benign. So what are some worrisome risk factors that kind of points towards a malignancy? So what can they tell you that should already ring bells that this is not a regular thyroid nodule that's benign? If they tell you about some kind of ionizing radiation. Now, there are two types, cases where you would get ionizing radiation. If you were a nuclear fallout, so it's specifically they say this patient is from Chernobyl or this patient is from Fukushima, then obviously that's going to be signed, but they're not going to tell you in an exam because it's highly rare. So, but they will tell you that this person, when they were a kid, radiation treatment for a lymphoma, right? Or some kind of radiation treatment, some kind of malignancy. Usually it's a lymphoma on the kid, right? Men, elderly, and children, they're higher risk factors. Obviously, if you have a family history of thyroid cancer, that increases your risk that this nodule might be cancerous. And medullary thyroid cancer, we're going to get back to it, to a very familiar slide about medullary thyroid cancer. Now, I think this picture illustrates some very good points about thyroid cancer and the worrisome factors. So women, 75% of the cases are women. So that means, that's the run-of-the-mill thyroid cancer, right? So that means if you're a man, elderly, and children, so you're a little bit higher risk. You're not a run-of-the-mill. You're not a common population that's going to get it. Happens between the age of 20 and 55. Children are below the age of 20, so that means it's a little bit more higher risk. And elderly are above the age of 55, so they're a little bit higher risk too. But in this population here, they have a 98% survival rate, right? But these guys are a little bit higher risk, so they will have a worse survival rate or highly worrisome disease. Now, medullary thyroid cancer, remember the MENs, right? MEN 2A and 2B, you'll have medullary thyroid cancer. But since medullary thyroid cancer in 2A and 2B coincide with pheochromocytoma, you want to worry about pheochromocytoma first. So if they have medullary thyroid carcinoma, before you go take them to the OR or do anything, you want to rule out if they have pheochromocytoma, right? Actually, 25 to 50% of people who have medullary thyroid carcinoma actually have MEN disease. So this is where you get worried about. And medullary thyroid carcinoma, as we'll discuss, is releases calcitonin, and that'll be your number one. But what I want you to get from this slide, we covered this ad nauseum in the endocrine lectures, is the fact that if you have medullary thyroid carcinoma, you want to rule out pheo first, because that's a surgical emergency. All right, so somebody comes in, you discover a nodule either by physical exam or ultrasound discovers it, right? What's the first thing you do? The first test you order is a TSH. And usually they could trip you saying by TSH reflexive or just regular TSH. What does it mean by reflexive? Reflexive tells you that if the TSH is abnormal, they're going to measure your T3 and T4. That's all that means, right? But the first thing you always order is a TSH. Because that falls down, remember what we discussed, our general picture is that when you have a thyroid nodule, you want to rule out if it's functional versus non-functional, and then benign versus that's not benign. All right. So you measured the TSH, abnormal, but you still got to do another test. You do an ultrasound, right? You do an ultrasound to get a size measurement, and you actually want to make sure that is actually a nodule in the thyroid before you go biopsy it down the road, or it's something else. Maybe if it's a lymph node. So that's going to help you with your management. So you measure your TSH, you get your ultrasound, right? And you find that your TSH is suppressed. What does that tell you? If your TSH is suppressed, that means you must have elevated T3 and T4 that's suppressing the TSH, right? So that makes you worried that this nodule is actually secreting thyroid, T3 and T4, that is functional thyroid hormones, right? So what do? Then you want to make sure that if this nodule is hyperfunctioning or it's not hyperfunctioning. This is where it comes with your iodine scanning, right? So radionuclide scan, iodine, 123 scan, they're all the same thing. So you do the scan, and this is what a hot nodule looks like. So the one part of the nodule is, this nodule is active, it's secreting a lot of hormone, it is suppressing your TSH, and because you're not having a lot of TSH come to your thyroid, the rest of your thyroid is shut down, but this one is functioning by itself. And this is what a cold nodule looks like. So the rest of your thyroid gland is actually working pretty fine. There might be a disease in the rest of your thyroid, but the cold nodule itself is not hyperfunctioning anything. There's a nice picture in between the two. So if you have a suppressed TSH, that means it's hormone secreting, right? That nodule is called the hot nodule. Another name, if it's single, it's called a single toxic nodule, right? It's toxic, it's secreting a lot of thyroid hormone. Good thing about it is that if you have a hot nodule, it's less likely to be malignant. And patient will have symptoms of hyperthyroidism. So what are some of the symptoms? You have weight loss. One thing I want you to pay attention to that's very high yield for thyroid disease and hyperthyroidism is increased pulse pressure. Right? What do you mean by increased pulse pressure? So pulse pressure is the difference between your systolic and diastolic blood pressure. So if you have a normal person who has 120 over 80, so the difference between that is 40. So that's around the normal pulse pressure. But they'll give you blood pressures like 130 over 55. So your pulse pressure is 75. That's very high. I want you to remember this. In your exams and in your step 2 and beyond, when you're taking these board type of examinations, when you see increased pulse pressure, that should make you think of two things: a hyperthyroidism or aortic insufficiency. It's going to be one of those two. And we'll cover aortic insufficiency in our cardiothoracic lectures. All right, heat intolerance. Obviously, if somebody's hyperthyroid, that's a very common buzzword. This is heat intolerance, because metabolic is so active that you're always feeling that you're hot, because your rest of metabolic rate is high. Women will have irregular menses. Now, what do we say? One of the things of T3 and T4 is you increase your catecholamine effects, right? Your heart's you gotta be tachycardic, which could lead to atrial fibrillation. And one thing that you usually don't pay attention to, if you have hyperthyroidism for a long time, it causes connective tissue or increases your chance of valvular disease. And since women are more likely to have this kind of nodules, one of the common things is mitral valve prolapse. weaken or damage your chordae tendineae, so it damages your mitral. So what we'll describe in the case, this lady has a tachycardia and you could hear a mid-systolic click. So some of the things that will point you towards that this is some kind of hyperthyroidism disease. What's the treatment? So remember that hot nodule is secreting thyroid hormone. And thyroid hormone, what's it made out of? Essentially, iodine, right? Iodine is the base of how do you make thyroglobulin and the thyroid hormone, right? But since single toxic nodule is secreting all the hormone, it's very iodine avid. It really likes iodine compared to the rest of your thyroid glands. It's very selfish, right? So you're like, oh, if you like iodine, then you could just give it a poisonous iodine, which is iodine-131, radionuclide iodine, radioablation, right? You give that, it's going to preferentially uptake into that nodule. So you're going to kill that nodule by just giving it a poisonous iodine. If for some reason the patient doesn't want that, or there's some contraindications, you could give medications such as PTU or methimazole, and we'll discuss it on the next slide. So some of the things that I want you to remember. You do not give radioactive iodine treatment in pregnant patients, right? Radioactive iodine, somebody's pregnant, it's going to cross the placenta, it's going to kill the thyroid of the fetus. And remember, thyroid of the fetus is very important for the development of the fetus, right? You get cretinism or mental retardation if you don't have the hormone for growth and development. All right, so you're going to have to treat them with the medication at that point. So what are the two medications we discussed? PTU and methimazole, right? PTU is safe in pregnancy. So pregnant patients get PTU. Methimazole is not, right? So you don't give that methimazole because it crosses the placenta, whereas the PTU does not. However, PTU has a little bit worse side effects compared to methimazole. So in the general population, non-pregnant females or in males, you give methimazole over PTU. They can both cause aplastic anemia, granulocytosis, so that increases your risk of infection. And what these both do, they block this enzyme, thyroid peroxidase. So if you block it down, you're not going to make the hormone. So what they'll describe you a typical case like this. The 38-year-old female comes to clinic. She has fever and she has tenderness in her neck. She recently got medically treated for a single toxic thyroid nodule, right? If they describe you that, and they have a fever and the thyroid gland itself is tender, that should already think this person has an infection, and it's because the fact that those medications decrease your white blood count, cause agranulocytosis, and so this patient is very high risk for sepsis because they really have no white blood cell count. So you stop the medication, admit them to the hospital, and address the issue. So how about if you have multiple toxic nodules, right? Or as it's known, toxic multinodular goiter, right? So remember, radioactive iodine is dose sensitive. So if I could concentrate, so if I'm giving 100 of iodines, right, it will kill that one nodule because all 100 are going to go to that one nodule. Now, if you have like 5 nodules, the 100 are going to divide by itself. They're going to go to 20, going to go to each nodule. So it's not effective because you could only give a certain amount. So it doesn't matter if you have 5 nodules or 1 nodule, you're still getting the same amount, but it's going to be less effective because if you have 5 nodules, it's going to have to spread among the 5 people. So in a multiple toxic nodule, surgery is your best treatment. You could do that medication to control the symptoms. So 1 nodule, iodine, multiple nodules, you could do surgical. That'd be the best treatment. So we discussed about cold nodule, right? It doesn't light up. It's not secreting. Now, if it's a cold nodule, they're more likely to be malignant compared to a hot nodule. For that case, you would do a biopsy by doing the fine needle aspiration, and you could treat accordingly to what your FNA result tells you. And we'll discuss this literally on the next slide. So we're going to focus on this side, right? Now we said if the TSH is suppressed, that means you're secreting hormone. Then you got to do a scan, see if it's a hot nodule or not. If it's a cold nodule, or if it's a nodule that's not secreting hormone, you want to do some kind of tissue sampling. So it's not a biopsy. You're not opening it and taking it out, but this is essentially a biopsy because you're putting a needle and taking the tissue out, right? And the size cutoff for you is 1 centimeter. If it's bigger than 1 centimeter, you want to do an FNA. Simple. Or if it's a cold nodule you're really worried about, so you go in there and do a fine needle aspiration. So 1 centimeter. 1 centimeter is very suspicious for malignancy. You do an FNA. So you do an FNA and you're worried about malignancies here. So what are the types of malignancies in a thyroid disease that you'll see? So in the thyroid, you have follicular cells and the parafollicular cells. The follicular cells are your inside of the normal thyroid. Parafollicular cells, they are the ones that secrete calcitonin. And other cells that could be there is lymphoma, sarcoma, or metastases. So we'll discuss one by one. The first one is a papillary thyroid cancer, right? So look, it says differentiated. So well-differentiated cancers, papillary and follicular, essentially are just, they act like normal thyroid tissue. So I want you to remember that normal thyroid tissue likes iodine, and these guys, these two, are well differentiated. So they will like iodine. So that will be helpful once we go down to the treatment. Papillary cancer. It's the most common thyroid cancer. 80 to 90% of the cancers, thyroid cancers, are papillary cancers. Has an excellent survival rate, 95% in 10 years. Some of the things they'll tell you on the exam is that they do a biopsy and you see internal calcifications or samoma bodies, right? That's like the buzzword. So they will tell you one of those. As soon as you hear samoma bodies on the thyroid, you know it's a papillary cancer. There's certain things that's going to give you samoma bodies. It's a papillary cancer of the thyroid, serous cystadenoma of the ovary, meningioma, and mesothelioma. So those are the four that give you samoma bodies. Majority spread to the lymph node. So by the time you actually feel the node and do a biopsy, there'll be a lymph metastasis. But that's not the, remember, metastasis in other types of cancer is what determines prognosis. In here, it's how much it invades into the thyroid tissue rather than a metastasis. So treatment. There's a lot of controversy and variation what each surgeon does, but there's some rules you want to follow. If it's less than 1 centimeter, you take half the thyroid. It's called thyroid lobectomy. You take one lobe of the thyroid. If it's more than 1 centimeters, then you do a thyroidectomy. So 1 centimeter cutoff. More than 1 centimeter, you do a thyroidectomy. Less than 1 centimeter, you do a lobectomy. If your lymph nodes are involved, so for example, in your imaging, you see a metastasis to your lymph node. On your physical exam, you feel the lymph nodes. So then you do a lymph node dissection. So on the same side that the cancer is involved. So you don't do both sides, you do one side. So you do the lymph node dissection on top of the taking out the thyroid. Now, remember, if the lymph nodes are involved, that means it's a thyroid tissue that metastasized there. And remember, papillary thyroid cancer is well differentiated. It likes iodine. So that after the surgery, you give it iodine to kill whatever's left off. And then since you take out the thyroid gland, you want to give a thyroid replacement, which is in the case of the levothyroxine, which is synthetic T4. Now, they'll ask you a question: why do I have to give levothyroxine if you took half the thyroid instead of the whole thyroid? Now, remember, what does TSH do? TSH causes your thyroid gland to, grow, get bigger, or hyperplasia, right? It's what causes your thyroid gland to work. So if you have some kind of cancer, you want to make sure by giving somebody levothyroxine, you suppress the TSH. That means whatever cancers you left off doesn't grow, and you could give radioiodine to kill whatever the cancer is left off. So you give levothyroxine both in lobectomies and thyroidectomies. So remember at the beginning we discussed that if you have a lateral thyroid tissue, that is most likely cancer metastasis in lymph nodes. Which cancer it's going to be? It's most likely going to be papillary thyroid cancer. And the buzzword they use is called a lateral aberrant thyroid gland. So because papillary cancer is the most common, and it goes to the lymph nodes. So remember that. So let's discuss the follicular cancer. It's still a well-differentiated cancer of the thyroid gland, but it's a little bit different compared to papillary. So one thing I want you to know that you can now tell the difference between a follicular cancer or a follicular adenoma, right? Adenoma is just the growth of the follicular cells, versus the cancer is a cancer. Now, what is a FNA? So this picture with the peach actually shows what FNA is. You put the needle into the peach and you suck out the cells. Now, you can't tell if that cancer is actually invading the wall or the skin of the peach, right? That's what determines the cancer. It's growing beyond its boundaries and it's going to metastasize or not. So how are you going to find out? So let's say on your right lobe, you have your FNA shows follicular cells, right? If it shows follicular cells, you want to make sure that it's not a malignancy. So you take out the whole thyroid gland and analyze if it's going to invade the wall or not. If it's an adenoma or a hyperplasia, you're done. It's just follicular cells. But if it's a cancer, then you come back and you take out the whole thyroid, right? So once again, if you do an FNA and if it shows follicular cells, right, you're not off the hook yet, because that could be cancer or adenoma, but you don't know which one it is because FNA is not going to tell if you're invading the wall or not. So you take out the lobe that's involved, see if it's invading the wall, and if it's invading the wall, you come back and take out the rest of the thyroid. So you determine that it's a follicular carcinoma. What do? You take out the whole thyroid, and after surgery, you give radioactive iodine. Remember, follicular cells are well differentiated. Well-differentiated thyroid tissue likes iodine like a normal thyroid tissue, right? So you're going to kill whatever's left off. And after surgery, since you're taking the whole thyroid, you're going to give levothyroxine, and it's also going to help you suppress TSH, which is going to suppress the growth of more whatever cancer tissue is left off. Important to know, follicular carcinoma, unlike a papillary carcinoma of the thyroid, does not spread to lymph nodes, right? It spreads hematogenously. It's going to go to your bone or your lungs, right? So you don't need to do lymph nodes. If you see a lymph node dissection for a follicular carcinoma, that is not the answer choice. You should not pick that answer choice. So it spreads hematogenously, unlike other carcinomas. So let's talk about the anaplastic. Anaplastic is very rare. It is a very aggressive cancer. It's usually in an elderly male. It's kind of growing really fast. Surgery is palliative care only, so you do that to control the symptoms. You could do radiation, but it's the mortality risk is so high that there's not much you could do unless you need to control the symptoms. Medullary thyroid carcinoma, that's a very high yield. We saw the picture MEN2A or 2B. Usually if you see a medullary thyroid carcinoma question, or if they're hinting at you, they want to ask you a question about MENs. So what is a medullary thyroid carcinoma? It is from C cells in the thyroid, right? The C cells secrete calcitonin. If you have too much calcitonin, ironically, some of the symptoms that you have is flushing and diarrhea. Nobody knows why these symptoms are, but these are the first symptoms that the patient feels. Another hint they'll give you that there's a lot of amyloid in the cells. So that's a buzzword. If they tell you there's thyroid biopsies done or FNAs done, there's a lot of amyloid, you should think medullary thyroid carcinoma. And it tends to metastasize liver and bone and lung. So it's very highly, by the time you come in for a surgery, it's highly likely that 50 to 70% of the time it's metastasized to some organ. So what do you do? So regardless of what the size is, you get a total thyroidectomy for medullary thyroid carcinoma, right? And you're going to have to do some kind of a lymph node dissection. If the cancer itself, the nodule, is more than 1 centimeters, you do a lymph node dissection on both sides, so right and left lymph node dissections. If it's less than 1 centimeters, you do just on one side. So you take the whole thyroid, both the right lobe and the left lobe, and then you look at the size. So if it's more than 1 centimeters, both lymph nodes get dissected. If it's less than 1 centimeters, only one side. And then you follow the calcitonin level to see if there's a recurrence, because remember, C cells secrete calcitonin, and medullary thyroid carcinoma is the cancer of the C cells. So they tell you that the mom and dad have MEN, or mom or dad had MEN2A or 2B. They do a genetic test when the kid is born, and they know that this kid has one of the MEN2s, right? What do you do? So remember, medullary thyroid carcinoma is usually the first manifestation of MENs, right? So once the kid gets beyond age 1, remember up until age 1, thyroid hormone is very important for brain development. After age 1, you will do a prophylactic thyroidectomy, and it's a very high yield topic to know, not just for the surgery shelf, and also for the pediatric cells that you'll take. And the last one that I want to discuss with you is the other cells. Now, sarcoma metastasis to the thyroid are very rare, so we're not going to cover that because it doesn't tend to show up on the exam. But lymphoma, there's specific things that you would like to know about the lymphoma. Very rare, but commonly on the exams. It's usually a B-cell lymphoma, and where does that happen? Is in the patient who have a long-standing Hashimoto's. In part 2 of this lecture, we'll discuss some of the things with Hashimoto's disease, but I want you to remember that in Hashimoto's disease, you have a lot of lymphocytic infiltration of the thyroid gland, right? If you have a lot of lymphocytes there, if it's there for a long time, it's going to develop a lymphoma. That's how you like to think about it. All right? And then this is the algorithm that you want to go over. So again, measure the TSH. That's your first test. If it's suppressed, that means it's hyperfunctioning. You do a scan. If it's normal, you're worried it's the cancer. You look at the size, you biopsy it with an ultrasound, and you do a surgery or you follow them up. Now, I know you're going to read a lot of books where they discuss about different types of results from an FNA. But essentially for the exam, you need to know if it shows malignancy or suspicious for malignancy, you go to the OR. If it says unsatisfactory or not enough sample, just go take another FNA. All right? So just don't overcomplicate it for you. And one thing is, no matter what kind of nodule you have, if it's bigger than 4 centimeters, that's really worrisome for some aggressive cancer. So you want to do a total thyroidectomy. It doesn't matter if it's a papillary or follicular. So just remember that. If it's more than 4 centimeters, they get a whole of their thyroid taken out. All right. And for the exam, remember, thyroid cancer patients are going to be euthyroid. That means they're probably not, what they want to tell you that nodule is cancerous if their thyroid levels are fine. That means the whole thyroid gland is functioning fine, but that part of the cancer is not secreting anything. So that's what they'll tell you. All right. Some complications that you want to worry about for the exam. We discussed the recurrent laryngeal nerve damage, right? They'll have hoarseness or stridor after the exam. So you want to evaluate the vocal cords. Common thing is, a lot of patients, because the recurrent laryngeal nerve is so close to the thyroid during the surgery, going to get this thing called neuropraxia. Essentially what you're doing is you're stretching the nerve. So they could have transient 1 to 2 weeks hoarseness that's going to go away. So if they describe you the patient who had hoarseness and comes back to clinic for follow-up and they don't have it anymore, well, they want you to know that it's a neuropraxia. You stretch the nerve, now it's you bruise the nerve essentially, and then the bruise kind of went away. Another common complication and worrisome complication and a high-yield complication that you should know is a post-op hypocalcemia. We discussed this in our parathyroid lectures. So what can happen is you could damage the blood vessels to the parathyroid or damage the parathyroid glands itself and can give yourself a very dangerous hypocalcemia. How would they tell you if the patient has perioral numbness, tingling, muscle spasms? What do you want to do? You could measure PTH, obviously, but before you do that, you give the calcium and you give calcitriol. So why do you give calcitriol? Because that's an active form of vitamin D, and you're going to start absorbing calcium really fast. And after that, you could do PTH measurements and see if their calcium levels fine and follow their calcium. Why is hypocalcemia worrisome? Remember from our parathyroid lectures? Correct. If you have hypocalcemia, it's going to prolong your QT. It can cause a cardiovascular arrhythmias and collapse, so worry about that. Last but not least, neck hematoma. We covered this in the PTH surgeries as well, parathyroid surgeries as well. So one thing they'll tell you if somebody's in a recovery room 20, 30 minutes after surgery and now they're having stridor, the wound on your neck where they took out the thyroid is tense. They're having difficulty breathing. The key is you decompress it, then go to the OR. So wherever they are, they could be on the ward, they could be in a recovery room. You decompress it there. So literally take the scalpel and cut it out and open the wound and take the patient to OR right after. So you don't go to the OR, then decompress it. Decompress, then go to the OR. So these are the questions that we come back to again. What are the size concentrations? Remember, more than 1 centimeter is worrisome. You want to do a biopsy. And if it's more than 4 centimeters, you want to take it out. And if it's, especially if it's a cancer, you take out the whole thyroid. What are the medical management options do you have? You could do radioactive iodine 131. Or you could do PTU or methimazole. Remember, PTU is safe in pregnancy, methimazole is not. Surgical options. Medullary thyroid cancer, get the whole thyroid comes out. And if it's bigger than 1 centimeter, you do lymph dissection on both sides. If it's less than 1 centimeter, you do a lymph dissection on one side. Same thing with the papillary and follicular. Follicular, you want to do an FNA, see if it shows the follicular cells. If it shows follicular cells, then you got to take half the thyroid out, wherever side is on, to make sure if it's invading the wall or not. If it's invading the wall, that tells you it's a cancer, you take the whole thyroid out. And then you could do lymph node dissection depending on the size again. And papillary thyroid cancer, so it's going to most likely metastasize to your lymph nodes, but you look at the size. If it's more than 1 centimeter, you take both sides. If it's less than 1 centimeter, you take one side. We discussed where FNA comes in help and when you do a total partial thyroidectomy. This concludes the part 1 of this lecture, and in part 2 we'll discuss some of the genetic thyroid disease that you need to know for the surgery shelf. All right, see you soon.